Okay, as the clock ticks around to 6:30, welcome everyone who's joined on time. Very warm welcome to Ellie Alexander, consultant virologist from Barts Health, who's here this evening to talk to us about COVID. And also to, as part of the presentation panel, Leslie Perkins is with us, who has a lead role in fact, Leslie, do you want to unmute yourself? And I'm going to get it wrong if I describe you as the guru of diagnostics. I don't know your exact title, but I know that you're incredibly helpful when it comes to diagnostics on the WhatsApp diagnostics group, and lead for well in that area. But I'm ashamed to say I don't know the exact title. So
no, it's totally fine.
Introduce yourself.
I'm the Well clinical lead for diagnostics, so work closely with the lab, and have met Ellie previously when we were talking about some other things, but obviously recently it's become more important to increase our relationships with the lab and get kind of webinars like this going. So thanks.
Wonderful. Thanks for introducing yourself. And I'm sure many of you will have heard the news this morning. Alison Pollock was on the Today programme that I heard, talking about tests for COVID, and I think 7 or 8 people have signed a letter to the BMJ. There's also an article about, a briefing article about COVID antibody tests in the BMJ, written by a freelance journalist, which were published yesterday. So many of you will have seen those, and I'm sure Ellie, I think, has probably also seen them, and will be able to answer any questions on those. So anyone who wants to put any questions forward, please do so in the chat in the normal way. If you can keep muted during the talk, it really helps the presenters when they're giving their talks. But we can take questions as we go. If you put them in the chat, I'll put them to Ellie. So without any further ado, Ellie, can I ask you to introduce yourself and start the presentation? Thank you very much indeed.
Okay, hello everybody, and good evening. It's a bit hot and sticky. So I am a consultant virologist at Barts Health, but I'm also a paediatric infectious diseases specialist, and I'm recently appointed to the position of consultant in public health infection for the South East region. So I work across NHS and public health, and started the CPHI role as a new role at the beginning of April. So have sort of been immersed in COVID since the beginning. And as Leslie mentioned, we met probably at the beginning of the year, although it feels like years ago now, before all of this started up. And so what I'm going to do today, I haven't got loads and loads of slides. I'm going to talk to you a little bit about coronavirus, what it looks like. I'm not going to go through all of the history of how it arose, because I think most of us have seen those slides. So I'm just going to talk to you about the whole genome sequencing that's been carried out recently, and then talk to you about PCR testing and viable virus, and a bit about antibody testing. So if you feel that a question should be asked about a particular slide, it may be that we can take questions all the way through rather than waiting until the end. Let's see how it pans out. This is a phylogenetic tree of coronavirus, published in the Lancet earlier this year. Can you see my cursor if I move it around? You can nod.
Elisa, is it okay for you to set it up as a slideshow so the fonts will appear a bit bigger?
Yeah, there you go. Better? Yeah. Is that better? Sorry,
that's much better. Well,
it is very, very small. It is very, very small. It's not meant to be very big, but you can see where the coronavirus originated here from merbicovirus, nobicovirus, and then has gradually through the phylogenetic tree, you can see different clades have developed into different coronaviruses that have ended up in different species within different countries, some of them infecting humans down here. There's a human coronavirus, but it's not that far away from a mouse coronavirus. There's another rodent coronavirus here in China. Here you can see MERS-CoV, something that we're not hearing a lot about at the moment, but this is the camel-associated coronavirus with a very high mortality. And then as we move up, another bat coronavirus. And then here is our novel 2019 coronavirus, which is fairly homogeneous here. You can see that it's not that different when you sequence it, but between different isolates, different clades. But then you can see China features heavily in this bat coronavirus here. And then at the top, we have the original SARS coronavirus. So you can see they are all fairly closely related. There's not that much difference between the genetic sequences of these. And you can see how closely related they are when you look at the clades infecting humans and the clades infecting bats. And perhaps that explains how easy it is for it to cross over. So it just has to mutate a little bit and then it's able to infect humans. So it's a positive sense single-stranded RNA virus. It's around 30 kilobases in length. It's enveloped. It has a membrane. It has a nuclear capsid here. And then you can see these are the spike proteins. And these spike proteins become the receptor binding domain and allow the virus to bind to the angiotensin converting enzyme 2 receptor, which gives it its pathogenicity. This slide is defines the analysis of lineages within the UK. So these are the UK transmission lineages. And as you can see here, you've got January, and you'd expect that a lot of these lineages would have come from China. But actually, when you look, you can see China is purple here. And even when I can see this in quite close up, I can't see China featuring in these lineages at all. So this is the spread of coronavirus in the UK from around the beginning of February up until the end of April. And if you look to see that a very large number of importations are due to inbound international travel from Italy in green, Spain in red, and France in blue, and various other European countries. And the majority of those started around February, the week beginning February the 16th, February the 23rd. And if I remember rightly, that was around half term, I think. So all of the initial work that we did was around identifying people who had travelled from Wuhan and then mainland China. It wasn't until around after half term that we started to identify cases coming in from northern Italy, and I do feel that we were sort of already working. We were sort of chasing our tails somewhat when you look at this schematic of the importation of SARS-CoV since the middle of February. So I'm going to talk a little bit now about the viral dynamics and the duration. I'm trying to move the box so that I can see there we go. So the viral dynamics and the duration of viral shedding measured by real-time PCR. So this is PHE UK data on 74 UK high consequence infectious diseases cases. So this will be the first 74 cases that were identified. If you remember right back in the beginning, any case of SARS-CoV that was identified was cared for in a high consequence infectious diseases unit, so either at St Thomas's or the Royal Free or Manchester and Newcastle. So at that stage, in containment stage, it didn't matter how unwell they were, we kept them in isolation. So the first 74 cases demonstrated that viral RNA remains detectable until around day 28 in upper respiratory tract secretions. So in those initial cases, they would have taken nasopharyngeal swabs, they would have taken lower respiratory tract secretions, they would have taken all sorts of different samples to look for viral RNA. And they saw that if they compared the comparison of day 1 to 7 versus day 8 to 15. Oh, sorry, my hands are so hot. You can see here that you've got a significant fall in viral load. So if I show you in figure A, you've got days post-symptom onset along the bottom. And then you're all aware that the higher your CT value, the smaller amount of viral RNA you've actually got in the sample. So the CT value is the cycle threshold for the PCR, and the more times you have to go through, the more cycles you have to go through, the more you have to amplify the virus to actually detect it. So a higher CT value equates with a lower amount of viral RNA. And you can see on this graph here that you've initially, this is day 0, days post-sample. At day 0, you've got a CT value of around 30. But as you go out here, it's the other way around. So you've got a CT value of around 40, which is generally our cutoff. And as you can see, as you go further out from symptom onset, the CT value falls. A further study done in China looked at a total of 414 throat swabs from around 94 patients, and that was from symptom onset right up until 34 days after the start of symptoms. And in this data set, so this is a slightly different study, more patients, and they showed a rise in the CT value beyond day 14, and there was no obvious CT difference across sex, age groups and disease severity. So if we look here, you've got 6 different situations here, 6 different, the CT value, I don't know, can you see this? It's quite difficult to see, but you can see you've got mild, sorry, you've got mild cases here in the blue and severe cases here in the red, but you can still see that actually the further you go from symptom onset, the higher the CT value and the lower amount of virus that that you can detect. No difference here in age, no difference here in severity of disease, no difference in male and female. And this was just looking at where the virus had actually come from. So imported from Hubei in red and from somewhere else in blue, but again, no difference. There are some other studies. So Wolf et al. Presented early viral culture data on a small cohort of hospitalised patients, and the virus was readily isolated during the first week of symptoms. So from about 17% of nasopharyngeal swabs and about a lot higher in sputum samples. But there was no culturable virus isolated from samples taken after day 8. So despite still being detectable on PCR, they were unable to culture virus after day 8. And subsequent studies have, I think, day 9 has been the longest time period where culturable virus has been isolated. So early PHE data also find the latest time point in the data set was the sample where the virus was recovered at day 8 post-illness onset. And this suggested that a CT value of 35 demonstrated a reduction in the actual the amount of culturable virus actually there. But most of this data is very limited. It's not looking at big numbers. It's not large numbers of cases. So a report of the first 12 cases in the US, they attempted viral culture on initial respiratory specimens from 9 patients, and that was successful, which included 2 non-severe, non-hospitalised patients, and viable SARS-CoV was cultured up until day 9 in 1 patient, but wasn't attempted on later specimens. It's not something that's widely available. It's difficult to do. I think currently Colindale, the reference lab, is one of the only places in the UK that's able to culture this virus for us.
Ellie,
yeah.
Just in terms of the practical application of this, are you saying that really you can't pick up from a nasal swab 8 days after, or the ability to diagnose reduces with time, and after day 8 there's very limited point in doing a nasal swab?
No, not at all. It's so basically we have seen PCR positive swabs right up until 28 days post resolution of symptoms, but it doesn't mean that you are still infectious. So if you were to take a swab from a patient on day 0, 1, 2, 3 right up until day 14, you would still detect the virus, you would still detect viral RNA using your PCR test. But if you were to try and culture, which nobody does, it's really, really complicated to do, it's difficult, and obviously you don't really want live virus sort of being cultured in a laboratory. But if you were to try to extract the virus and grow it from the swabs, by the time you get to day 8, it is almost impossible to do that. So you will still be positive. So it's very different from a microbiological culture swab, where you swab somebody's throat and you grow it up on a plate. We are detecting viral RNA. It doesn't mean that that virus is viable. It can be bits of virus that are no longer viable, but they will still be detectable.
Okay. If I was summarising that, you can detect the virus, but you don't think it's viable after day 8.
Yeah.
Right.
So if you had somebody who had a good history of a COVID-like illness 4 weeks ago, and you took a nasopharyngeal swab and sent it to the laboratory for testing, it may well still be positive. The chances are that CT value will be way over 35. So that means that the number of cycles you have to go through, the number of cycles of amplification you have to go through to detect the virus is more than 35. That's a lot. And our cutoff is 40. So when we have to go, if we have to go over 40, we release it as a negative result. It's negative, essentially. Does that make sense?
I think it makes sense. I think Emma is asking the same question, really. So does the number of CTs mean that it is less infective, or how do the swab results relate to infectivity?
So the higher the CT value, the more cycles of amplification you've had to go through to detect viral RNA. So the higher the number, the smaller the amount of viral RNA you had in the first place. So if I have to go through 35 amplification cycles to be able to detect any virus at all, it means that there was virtually none there to start with.
Okay, so a bit like an autoantibody dilution.
Yes.
Yeah.
Yes.
Okay.
Yes.
So that's useful. And is that reported, or is it just
No, we don't report, because so the other difficulty around virological testing is that everybody across, so initially Colindale were the only ones. They developed the test, they developed the PCR test at Colindale, and they tested every single sample, was sent to Colindale and was tested. And then gradually over time, the test was rolled out across the public health laboratories across the UK. So there's 8 in total. So it was rolled out nationally, but it was kept within public health. But in that same time period, you've got an in-house public health test, which we knew worked, but you've also got lots and lots and lots of companies who already have equipment within virology labs across the UK, which are used for PCR, developing a COVID test. So your initial rollout from Colindale Reference Lab to the national public health laboratories, you were using the same test. So we were using the same test for absolutely everybody. But then on top of that, you have Colindale validating all of these new tests that are coming in. You know, you've got companies putting their hands up saying, well, we can do this and we can do that. And then each different NHS laboratory across the UK would use a different platform for their PCR. So a different method of extraction and a different method of amplification and detection. So we can talk a little bit more about the problems we've had around reagents and the different platforms sort of towards the end. I've got quite a nice slide of how much we're doing now at the Royal London. But the other issue that you have within laboratories is you can't just do what you want. Most laboratories are wedded to a particular platform. They have a managed contract with that particular platform, which may last for 2, 3, 4 years, where you will have the providers of that platform will provide the reagents, and the reagents will be generally specific to that platform, but also they will provide the maintenance, and you pay. It's a managed contract, you have to pay. So different laboratories across the country will use different platforms, different reagents, different swabs in some cases as well. And at each stage you need to ensure, so if you're changing the swabs that you use, or you're changing the sample that you're testing, it has to be validated, because you want to know that if you're issuing a negative result, it really is a negative result. And if you're issuing a positive result, it really is a positive result. So initially, when COVID was identified as a major problem, companies internationally across the world would start to produce PCR kits to detect the virus. But then it's our job as public health and as virology consultants and virology scientists to ensure that those tests are valid, and that if we give you a result, it's a valid result and it's reproducible.
Okay, I think, yes, thanks for making that clear. That's very useful. Okay, so that could also explain why some tests which were negative in one hospital could be positive in another, and vice versa, because of the different specificities or sensitivities of the various tests that were being used.
So the difficulty we have with sensitivity and specificity is there is no gold standard to compare it. I think that initially there were issues with taking a nasopharyngeal swab, an aggressive enough nasopharyngeal swab to ensure that you detected the virus. But then we also didn't know when the best time to do the test was. Was it on day 0? Was it day 3, day 5? You know, it was, and the numbers initially were so small that that the guidance wasn't there. I think that it also depends on what sort of swab you use and how you transport that swab. To some swabs you can leave them lying around for, you know, days and days, and it's not a problem. Other swabs need to be kept in the fridge. Some samples need to be kept in the fridge once they've been taken. So there's so much variability in those initial stages that it means it's quite difficult to compare the results coming out of one laboratory with the results coming from another laboratory. Does that make sense?
No, absolutely. Yeah, thanks.
Okay, I think the last bit of this slide just says more of the same. This is a study that was done in Vietnam, again following a small number of patients, 30 quarantine participants, and the analysis of the probability of real-time PCR positivity showed asymptomatic participants, these are the ones in green, had faster viral clearance than symptomatic participants. And this difference was most pronounced during the first week of follow-up, which is up until about here. And then obviously after that, so the more severe cases appeared to have more positive PCR. So the probability of them being PCR positive was much higher. So you can assume from that they had higher levels of virus. Some community data from the States. So there was an outreach program in New York which identified people who'd recovered from COVID, and they included participants with very mild disease, and they recruited 1,343 people with an average age of 40 who all reported complete resolution of their symptoms 3 to 14 days prior to testing, and of these, just 19% was still positive. The maximum time was 43 days from symptom onset and 28 days from symptom resolution. So that just illustrates that you are still 20% likely to be PCR positive, you know, a long time after your symptoms have actually resolved, but it doesn't mean that you're still infectious. And one of the difficulties that this throws up, that so essentially these 1,300 people had all had complete resolution of symptoms, so they were asymptomatic, but there was still a 20% positivity rate. And we are looking within the NHS and probably the, you know, secondary and primary care, at screening our staff to identify those who are sort of COVID secure and can work with within a COVID secure unit with what we have deemed to be green patients at Barts Health. But if you were to screen a number of asymptomatic healthcare workers, you are very likely to pick up a lot of positives. And they're asymptomatic, and they're not necessarily going to be infectious, but if they've got no history of any symptoms, which is sometimes the case, it's going to be quite hard to know whether these are recovered and asymptomatic and recovered, or whether they are pre-symptomatic and are going to go on to develop disease in the next few days. So I don't know what experience you've had within your own practice of swab results. I don't know whether you've had, whether primary care has been offered any kind of screening at all, whether you've had lots of questions from various healthcare workers trying to work out what it means when they have a positive swab if they've been asymptomatic.
Yeah, I think one of our big problems was that early on we had no access at all to swabbing. Then there was a limited access to swabbing based on a geographical allocation of tests. So, you know, Waltham Forest had 8 tests on a Tuesday, Tower Hamlets had 10 on a Monday, or whatever. And then suddenly, which coincided with Matt Hancock's desire to have 200,000 tests done by the end of May, we suddenly got offered the opportunity one Thursday Thursday evening to send the test to the London on the Friday. So most practices, I think I'm right, but do put it in the chat, everyone. Most practices took the opportunity to have a blood test, to have an antibody test at that time. Okay, but so this is still the PCR. Yeah, so this is. Yeah. So, but we were then left with having to interpret the results of the antibody tests. And I think if I give our practice as an example, we ended up with 3 positive antibody tests, and 2 of those individuals on the Saturday, and 2 of those individuals had no symptoms at all. So we were then going down the road of thinking, is this IgG or IgM? If it's IgM, am I just about to show that I'm symptomatic? Or so we then went down the road. So we, as a practice, went down the road of popping over to Greenwich, booking ourselves a PCR test, and then getting that back within 24 hours, which were all negative as well. So that's a personal example. I don't know if anyone else wants to unmute themselves and give examples from other practices, but those were the sort of, so we didn't really have access to testing for staff or patients until towards the end of May.
So I think from my point of view, initially, when we were sending all of our tests, we were sending all of our tests away to Colindale right in the initial phase, and I think that was probably up until the end of March. I think, the time sort of disappears, but up until the end of March, I'm pretty sure we were sending everything to Colindale. So we were limited by the amount of tests we could do because they were all send away tests. Once we introduced it in-house, which, as I said, it needs to be validated, it takes time. You need to ensure that the primers and probes you're using for your PCR tests work, and that a positive is a positive and a negative is a negative. But initially, I think at that stage, we were suddenly swamped across secondary care. So it literally went from 0 to 60 in a matter of days. And the majority of our tests that we were able to offer were used up on inpatient care, with a small amount of staff allocation. And then, of course, the reagent supply was very tightly controlled by NHS England. And because the platform that we use for our PCR, the Roche platform, is a popular one across the UK, the reagents rapidly started to dry out. The other difficulty, I think, with the super labs, so the Milton Keynes, I think, is the nearest one to London. They were set up to achieve Matt Hancock's 200,000 tests a day, but they were, I think, very hard to access, and certainly almost impossible if you weren't displaying any symptoms. So in the initial stages, I think it was hard for everybody to access the tests that they felt that they needed. But also, I think it was difficult from a laboratory perspective, in that we wanted to help, but we were totally limited by the reagents that weren't coming through. And that was reflected in our turnaround time a few weeks ago, or probably a month ago, where we were having to send tests away to another laboratory because we just didn't have the reagents to support our own trust. So it's been really difficult.
It's no criticism. It's just
I know. It's just, I think it's good for you to understand, I guess, just how hard some of it has been. That it's it was frustrating because the reagents were not necessarily going where the greatest need was, not necessarily in the UK, but going elsewhere internationally, where perhaps they were paying more. So it's been really difficult. It has been really difficult.
Yes. So Leslie, you've got a few comments. Do you want to unmute yourself and just make the observations about the TQuest availability of testing? I know some people have been using viral swab, non-specific, and then writing it in the comments box. I don't know whether that's the right thing to do or not. Do you want to unmute yourself, Leslie, and speak?
Yeah, so it was just to say that I think, as Ellie's alluded to, the reagent issue for them in the lab is the main kind of stopping point for it having been like fully released to everybody to have access to, and so that's why it's not available on TQuest. Ellie, I think there may have been a couple of people across Well who've maybe written it in a TQuest box, in the comments box on TQuest, rather than having an order, and so some tests have come to you that way. So, but I don't know whether that's the correct procedure. And at the moment, we haven't got the kind of go ahead to open it out to TQuest access for swab testing.
So from my point of view, I got involved with the care home testing quite early on. I think that there were GPs from Newham who were very keen to do some pilot screening in care homes, and Spiro, who is our clinical virologist scientist who supports us with all the IT, he found it. I think it's very, very straightforward to set it up on TQuest. I think it was, again, in the initial stages, there was concern that we were just going to get flooded and we wouldn't be able to support the testing that was required. I don't know if anyone's been successful by writing SARS-CoV PCR in a. I'd be interested to know, actually. I mean, it's quite inventive, but it's straightforward to set people up with TQuest to request a COVID swab.
So I think there was some sharing of local information about that on the WhatsApp group. I'd have to look back, but I'm pretty sure that's what someone said that they'd done.
Yeah.
There's a few more questions coming through actually now. So there's a question about government testing. Can children get tested?
Yes.
And from what age?
Well,
question of the sinuses with no demonstrable fever or cough. Should I be sending her for a swab even if she's asymptomatic? Tricky to interpret the antibody test. How should I proceed?
So I think I'm going to come to that in a bit, because I haven't talked about the antibody testing at the moment. I think that I've certainly seen colleagues who are positive, who haven't really, when they think about it long and hard, they've said something similar. You know, I didn't feel great in February, but I thought I was just stressed because it was really busy, or I felt a bit tired and a bit achy for a couple of days. So I think that if most people, if they really think hard about it, can identify some degree of symptoms. I think if you absolutely got nothing at all, then you could consider doing a swab, because there's that potential that if somebody's been totally asymptomatic and we've had an antibody test that's positive, that you could be in that either asymptomatic or pre-symptomatic period. Yeah. But it's really tricky.
Yeah. No, I think that's and that was we were making it up on the hoof on that weekend, and that's exactly the thoughts that we had. So I'm glad to have some sort of validation of that.
To be really, really honest with you, I think nobody really knows what's going on with this virus. Certainly not with the antibody. Shall I carry on with? Was there any more questions, or I can't see the
no,
chat?
I think we're through the questions now. Let's crack on.
Okay. So, hang on. Okay, so moving on now to serological responses to SARS-CoV-2. Antibody responses are observed in most people 10 to 14 days after infection, with peaks around 21 to 28 days, which could suggest a potential fall in infectivity from day 14, but that's not definite. Some data from the Dutch, which isn't published yet, suggests that there is less than 5% probability of culturable virus if the observed neutralizing antibody titer was greater than 1 in 80. So I think that what this is saying, and it's when you start to look at the antibody studies, they are small numbers. Obviously, over time, studies will come out using bigger numbers, but most of the studies that are published at the moment are only looking at, up to 500 serological samples in maybe 200 patients. But it does show that there is, it's thought that as your antibody rises, there is a drop in your infectivity. So if you have antibody, you are unlikely to be able to have culturable virus. Does that make sense?
Yeah.
Okay, and this is data, I can't remember the exact numbers. It's again small numbers of cases looking at your IgM response and your IgG response over time from symptom onset. And this is looking at mild cases, asymptomatic cases, severe cases, critical cases. And you can see that actually your IgG, so if you think back to when you were a medical student and your IgG, IgM responses to viral infections, your IgM goes up early and then it settles. And then so as your IgM starts to fall, generally your IgG starts to go up. But if you look here, you've got a rise in IgG really early on. And the IgM's kind of all over the place, and it doesn't really, I mean, obviously the majority of these cases were mild, but you've got asymptomatic in there. You've got some severe with quite high IgMs, but you've got severe with quite low IgMs as well. And was this a problem with the test, or are these real readings? And when you look through the studies that have been published so far about serology and about the serological response to COVID, it's quite confusing. It's really not clear what the serological response, what's it actually doing. It doesn't seem to matter in a lot of studies whether you have severe disease or you're asymptomatic, but then in other studies it looks as if you have a greater antibody response when you have severe disease, and that actually your antibody response is less in asymptomatic or mild disease. So this study was published in CID in March of this year, and it shows the sequential seroconversion post onset of symptoms. However, the sample size is small. It's only 173 patients with a total of 535 blood samples. But you can see here that over time, so days after onset of symptoms, your RNA detection decreases and your total antibody increases starting at around 11 days. Your IgM and your IgG increases. But there was no difference in this study between severe and non-severe cases. And they picked 9 separate cases, so 6 non-severe, 3 critical. And you can kind of see there's a bit of a spike around day 10 to 15, and this is your IgG. So the purple line at the top is the limit of detection of viral RNA. So that's when you become PCR negative. You can see some of these patients become negative and then become positive again. But there seems to be a bit of a spike in the total antibody at around day 10, but it is a little bit all over the place. And again, we can see here that even though the numbers aren't huge here, you've got really early detection of IgG. So you've got good IgM response, good IgA response, but you've got an IgG response as well. And again here, there's your IgM response at day 0 to 7, and then it decreases, but you've got a strong IgG response at that stage as well. So it's really difficult to interpret. It's really difficult to know what that means. And the big question is whether if you seroconvert and you have antibodies to SARS-CoV, are you immune? And this is a study that was done in 2016 with the first SARS-CoV-1 outbreak, where they looked at IgG and neutralizing antibody at 1 month, 4 months, 7, 10, 16 and 24 months after onset of disease. And the antibody, the titers peaked at around 4 months, and they were detectable up until 16 months in everybody. However, in around 12% of cases, they had undetectable levels of IgG and neutralizing antibody after 24 months. So 2 years after onset of symptoms, they didn't have any antibody left. And that is the concern, and that is why, if you look at the comments that are put on your antibody results, it says that if you're positive, you've been exposed, and if you're negative, you haven't been exposed. But it doesn't make any prediction around whether you are immune or not, which I think is really, really important. Does anybody have any questions regarding the serology testing?
So there's a question coming in from Ricardo. Is there any value in doing both tests? I think we've probably covered that, but I don't know if you want to go back and...
So I think in certain scenarios, I think perhaps it is valuable to do both tests. I think that if you've got a positive antibody response and you're asymptomatic and you've never been symptomatic, that actually a PCR test would be very reassuring.
Okay, thanks. Nicola, you've got your hand up. Do you want to come in?
Thank you. Sorry. Thank you. Sorry, I can't seem to type in a question, which is why I was just going to ask. So I had a positive PCR and a negative antibody test, and I just don't understand that.
So when was your PCR test?
My PCR test was about 6 weeks before my antibody test.
And you had an antibody test done at the Royal London. You didn't do a
I had the London antibody test.
I mean that's exactly the difficulty that we have, is that we don't really understand what it means. Did you have mild infection? You don't have to just.
I had mild infection. I was very mild. It's but my husband had a more severe infection, which is partly why I got tested. But I was very mild.
So it may well be that your mild infection has led to. I mean, it's possible that it would be a sensible thing to do to have a repeat antibody test in a month. I certainly wouldn't do it before then. But
is it a recognised thing that you can have a negative antibody test?
Yeah.
Right.
Yeah.
So Roche were claiming 100% specificity, weren't they? And or were they claiming 100% sensitivity? Gosh, I need to go back to medical school, I think. Which would, so they were, I think they were claiming that, weren't they? Or have I got that wrong somewhere? I'm frantically looking at the...
I'm not aware that that's what, I mean...
Yeah, so the Roche tests were 87% sensitive,
yeah, but
100% specific is what they're claiming, but that was on a very small number of patients, I seem to remember. Is that, but I'm going from that Radio 4 stats program, which probably one up from the journal in the, an occasional journal in the Dog and Duck. But so are you saying that if you have a false, that there are significant numbers of false negatives rather than false positives? 83%. What are you saying there, Ellie?
No, I'm not. I haven't seen any. I haven't seen any published data from Roche as to 100% specificity.
That's their referenced claim. But again, well, actually, it's a reference claim by Public Health England, actually, in the BMJ.
Is that from the article that was published today?
So
the
that's
letter that was published today.
It was, for those, I don't know if anyone else heard it, but there's a I can't remember the name of it now, but there's a stats program on Radio 4 that comes on about 9:30 one morning that looks at all the stats, and I can remember them saying that the Roche study looked at very small numbers of patients, but they obviously, the figures were quite impressive in terms of 100% specificity, and as a role, more or less. Thank you, Rachel. It's called more or less. Yeah, so that's that. Now, of course, there's loads of questions coming through. So Roche did that test on 95 hospital patients apparently, and claimed 100% sensitivity at 40 days or so. So that's things. There are a few more comments coming in. Do you want me to field them to you, Ellie?
Yeah, I can't. Yeah, you or people can ask. I'm quite happy to do either.
Okay, are there any studies of antibody positive people subsequently getting symptomatic with COVID?
No.
Okay.
As in no studies that I'm aware of currently. Anecdotally, there are a few stories of people being having COVID, positive PCR swab, improving, like completely improving, back to work, having another exposure, separate exposure, and becoming unwell again, with confirmed on a positive swab, but not that I'm aware currently that we have antibody results from.
Okay, so
we weren't measuring it at that stage. I'm sure there will be studies. I'm sure there will, but not currently that I'm aware of.
Okay, so do you have any figures? Tessa is asking about the sensitivity and specificity of local tests, or is that too early?
So it's too early, but we have, if I just go to, so this is the number of tests that we've done so far. We've probably done a few more than that actually, but that just gives you the turnaround time. But it's certainly something we can look at. We've got lots of data on from occupational health on staff who've tested positive, who will have had an antibody test, and we are looking at mapping those results. So positive antibody, positive PCR.
Okay, so I'm probably confusing things here, Tessa, but Tessa's asked to clarify which tests we're talking about the, is it the PCR or the antibody for sensitivity and specificity?
So we don't have sensitivity and specificity for the PCR test.
Yeah.
Initially, we had a look at severe cases on ITU where we had an initial nasopharyngeal swab that was negative, and then we had a lower respiratory tract sample that was positive. And that happened initially in, I think, about 6% of cases, maybe a few more than that. But
okay.
it's you know, the amount of infections out there currently is dramatically reduced. But no, so there's no gold standard to compare that PCR test.
Okay. We're coming up with 5 or 10 minutes to go, so there's a few more questions I'd like to get in.
Okay.
Rachel, you've had your hand up very patiently. Do you want to ask your question direct? Rachel? Okay.
Can you hear me okay?
Yes, we can now.
Yes.
Yeah.
It's partly clarification and then a question. The clarification was about what you were saying, Phil, in the more or less programme. And there was something circulated on the WhatsApp as well about the Roche study was its own publicity, really, on 95 patients who were tracked. But they were seriously ill hospital patients with the illness. And over the course of about 40 days, all 95 of them became antibody positive. So they were claiming from that 100% sensitivity. But there were other studies in another thing circulated on the WhatsApp saying that people with milder illness, maybe if they just have a myeloid or T-cell response, that they don't become antibody positive. And that would fit with colleagues that I know had the illness within their household who have been unwell themselves, PCR positive, somebody in the household, but then came back with a negative antibody test. That was the fitting in on the more or less programme.
I think it's difficult at the moment because the studies that have been published so far, the numbers are small. The numbers are really quite small. I think that you know there's probably a whole, and also if you look at severely ill patients who have come off
Event.
ITU. Yeah, and I think it's also I think that there is evidence from what I remember that the more virus you have, the more severe your illness.
Yes. My question was based on, people can apply for self-swabs through .gov.uk, and I'm quite concerned that we could get a lot of like false negatives back that way. And, it could be a question of technique on the swab taking by the public. And I hear very variable reports on the sensitivity of the throat swabs, apart from the question of variability between sites. And you mentioned some other factors that could affect the sensitivity, like transport. But we've initial figure that we were told was about 70% sensitivity on throat swabs, but I've heard other figures of much lower than that. If there's sort of patient factors in self-swabbing, do you have?
Again, there are there's a big school screening study that's just been set up by Collindale that is just looking at doing nasal swabs. So if you I put some interesting resources at the end of this. There are some really good webinars on the HIS website, and also RC Path have some online learning resources where there's Kate Templeton talks about PCR testing experience in Scotland. It's very variable. I think at the Royal London we've not had concerns about recently anyway about false negatives. In the initial stages, possibly when we were using the in-house testing, but not recently. But as I sort of explained at the beginning, it's so variable nationally what platforms people are using, what extraction techniques they're using, what reagents they're using, that it's quite hard to measure sensitivity and specificity overall.
Yes,
and it's very laboratory.
Just National Test and Track program, and how clinical judgment, say by ourselves, should probably overrule some of the it should be taken in conjunction with the actual swab result for.
Absolutely, I think you've hit the nail on the head, and that's what we said very early on in this in the pandemic, with cases being admitted, that if we had a clinical suspicion that this was COVID, then it was COVID. It didn't matter that the swab was negative. And I think you're right. If they're going to a testing centre and they're either being swabbed in their car, or the swabs are being chucked into the car and they're doing it themselves, it is very variable.
Yes, we certainly had a patient come back from France who was having chemotherapy for osteosarcoma, who reported that when they were swabbed in England, it was much better than France, because it only went up the entrance to his nose rather than right to the back, which was what they did in France. So that's one example. There are a couple more questions that are coming through. I think Savita has got a very interesting question, which is close to my heart. So if someone is known to be antibody positive, would you still need to self-isolate if contacted by the contact tracers as a known close contact?
Yeah, currently, yes.
Currently, yes.
So knowing that you're antibody positive actually doesn't change anything.
Okay, so it just means that you have been.
It means that, yeah, it means that you've had, yeah, it means that you have been exposed to COVID at some point and mounted an antibody response, and that's it. You, at the moment, it doesn't shorten your isolation. If you're told by the track and trace that you've been in contact with somebody, it doesn't matter that you've had COVID and you had a positive swab. It doesn't matter that you've got antibodies. You will still be expected to self-isolate for 14 days.
Okay, and leading on from that, Rafiq is asking, is there somewhere some guidance for primary care clinicians on how to interpret or consent for these tests? Is there some national guidance for that?
I'm not. You mean for the antibody testing?
Yeah, I guess so. Well, I should ask Rafiq. Is that what you're talking about, Rafiq? Do you want to unmute yourself? He may not be able to talk, but he has put in the chat, yes, I could not find any. So it is yes for the antibody test. So in the way that we were all encouraged, well, not encouraged, but it was made available, and many practices went hell for leather and tested all staff. I think we would all put our hands up and say, if we had our time again, we'd like to have some guidance on cancelling people for the test before we just blindly went for it. Really.
Yeah. No, I think that it's unfortunately sometimes feels that it's all about the numbers, and that actually it hasn't been as well thought through as it. I mean, I think as a surveillance tool, it's perhaps good to know how many people have had COVID over the past 6 months.
Yeah.
But
so what do you think at the London, Ellie? When all the staff were tested at the London, what process did they go through, and what use were the results? So
occupational health were managed it, and there's an ongoing clinic, I think, on a floor. I put my hands up and say I haven't been tested yet, only because I just haven't had the time to go up there. So from a personal experience, I can't tell you what the process is, but there is a consent process, but I don't know how detailed it is. I think there's also a process of finding out whether you've had symptoms, whether you've had a swab, what the result was, and then it's anonymised, so we don't have. But I presume all of yours would have been anonymised as well.
Well, you got the results back, so that they were anonymised in terms of. You did actually find out what the results were, whereas the RCGP trial, we're sending off bloods where you never find out what the results are.
Okay. So ours is all dealt with by occupational health. So if you would like me to write and ask them what consent process they're following, then I can find out, because I think it would be really useful for us all to be following the same process.
Absolutely. And Joe is just mentioning in the chat that apparently local pharmacies are now doing antibody testing. I don't know whether that's spot blood, Joe, or whether that's core venous samples. Is it? Do you know?
So CityDoc, is it CityDoc? Are doing they're doing antibody testing as well.
Yeah.
I think they're doing the Abbott, so they probably are doing separate IgG and IgM.
Okay. CityDoc, is that a private GP?
It's a private GP. They do. It's like a travel clinic. So I think that there are plenty of private places across nationally that are setting up antibody testing. That for £100 or whatever, you can go and have your antibodies checked.
Yes. There's I don't know if anyone has. We'll put the links on the information at the end, but there are a couple of papers in the BMJ today that, for those of you who joined a bit late, that talk about the antibody testing and also the letter from Alison Pollock and very many other luminaries around their concerns around the rapid rollout of testing. Good. So we're a little bit over the 7:30 time, so I'm conscious that we've probably reached the end. But I know that you've got some extra slides, Ellie. Are those information that we can pass on? Is there anything else that's vital that you'd like us to know about?
No, not really. I just wanted to mention the RCPath website, which has a coronavirus resource hub where there are about 10 different webinars around different aspects of testing. There's a serological one that I don't recommend that you watch, because it's it was completely above me. I watched it thinking I was going to gain an awful lot of knowledge, but it's not straightforward. But there's a really good PCR testing one. There's some PPE. There's just all sorts of different webinars to watch. And the HIS training events as well are something that's been set up by colleagues at Imperial. And again, they touch on various aspects of the pandemic and how to manage ventilation is something that's been quite interesting because it's been so hot and people have been asking whether they should be able to use fans and mobile air conditioning units in clinical areas. Also, the COG consortium, that's the COVID Genomics Consortium. So we are starting to do a lot of whole genome sequencing, looking at outbreaks. So the health protection teams keep an eye on exceedances across the country. So this is just looking at hotspots and trying to work out where they're coming from, and that's quite useful to know if you're seeing outbreaks in hospitals, to know what your community rates are. But yes, we can now sequence. So if there is an outbreak in a care home, and that it would be beneficial to sequence to see, whether it's one outbreak or three and where it's potentially come from. That's a resource. It's not fully functional yet, but I guess the best way to access that would be to go through the HPTs. So if you are notifying an outbreak in your locality, that we can send it off for sequencing.
Wonderful. I think there are two questions that I didn't cover, I've just noticed. So one was from Ricardo. So if you're antibody positive on these tests and you have the PCR done and that's negative, do you still isolate for 14 days or can you consider yourself clear to carry on? I
think you can consider yourself clear to carry on.
That's very good news because that's what I did. Not infected.
The people that so if somebody is asymptomatic and PCR positive, we will ask them to isolate for 7 days.
Sure, yeah.
But if you're antibody positive and you're asymptomatic and you have a swab and that's negative, you're fine.
Yeah, good. And important, I guess, from Simon is talking about occupational health is something that we don't really have any access to at all in primary care or for our staff. And his point is that Simon, do you want to unmute yourself and just raise your point, and maybe we can think about it for another time.
Sorry, can you hear me?
Yeah, perfectly.
Yeah. Hi. Sorry. Yeah. Thank you very much. Yeah. I mean, it just. I think what you know, all the examples that people have described just highlight the kind of complexity and the difficulty of this. And you always make reference to occupational health in the hospital. Unfortunately, we don't have easy access to occupational health in primary care. So I slightly worry that what we're doing is, and of course we have staff that we're responsible for who've also been tested. So I worry that we're all interpreting this in inconsistent ways, and it was really more a kind of open question about how we manage it, and actually more of a call for a kind of occupational health service that can support us when we have difficult results and difficult situations that we get put in. But I'll leave it as an open question.
I mean, I think that we're always pretty supportive in the viral. You could always just give us a ring in virology. We've got two very experienced registrars. We've got there's myself, there's Teresa. So if there's a question that you're really not sure how to manage, we should be able to help. We are providing a clinical service. We're doing the test. I think that we should back it up with a bit of support if it's needed. If you were to get a hepatitis serology query, you would ask, wouldn't you? You'd give us a ring.
Absolutely.
Yeah.
I'm not saying that we don't do it.
No. I think it's reasonable.
I slightly worry that we haven't been doing, and especially with all the conundrums that the serology brings up, which just makes it quite difficult. That's all.
I just think that we're all new to this, and I think that if you were to phone me and ask me a question and I didn't know the answer, I would have a chat with my colleague. And I think it's completely reasonable to pick up the phone and just ask, especially if you don't have, we've provided occupational health with plenty of guidance as to how to manage frequently asked questions. You don't have that luxury. we should be able to provide you support with how we are consenting people for antibody tests, but we could potentially, I think we have got some frequently asked questions as, you know, what does it mean if, that we could share with you, if that would be helpful.
Really
that would be incredibly helpful. If you could pass that through to us, we can circulate that on.
Would somebody just be able to email me?
Yeah,
and just because I've got a brain like a sieve at the moment, and it, you know, I wouldn't want to forget, but I will follow that up for you and share.
Yeah, we'll certainly follow that up, Ellie, as part of the post rollout of the recording and the chat FAQs too. So thank you very much for offering that, and thank you very much for the presentation tonight. I can see Leslie has her hand up. Do you want to just say one closing thing, Leslie, from your perspective? But from as far as I'm concerned, thank you so much, Ellie. If you could just stay on afterwards when we close down.
Yeah, sure.
On behalf of everyone. We've been wanting some expert virology, and you've certainly given it to us. Thank you very much.
Thank you.
Yeah, thank you so much, Ellie. I just want to reiterate that, and it's also almost comforting to know that it's not straightforward and it is complex, and you've got as you know, the questions that you have are similar to the ones that we have in terms of the kind of value of these tests and how they're going to be useful for us. I think I was just going to say, I think it's worth me and you, Ellie, maybe taking away some of the actions from this, and I'm happy to email you and we can try and sort some of this stuff out and then kind of send it out to everybody.
Okay, I mean, the other thing I thought that we could do is pretend that, you know, there were a lot of unanswered questions, and perhaps, you know, I think that there is an expectation that this will re-emerge in some shape or form over the next few months, or maybe in 6 months' time, and things will become clearer with regards to the antibody testing. And I don't know if it would be an idea to have a follow-up, you know, at some stage, maybe after the summer holidays, we could think about doing something similar in September and look back on this presentation and maybe answer some of the unanswered questions.
Yeah, I think that would be wonderful. That would be wonderful.
Okay, I'd be more than happy to do that. Thank
you very much. And again, thank you very much to you, Leslie, as well. And for everyone else, good evening and have a nice evening.